Hello, I am Dr. Madhurima, and today we are going to discuss the NEET PG 2023 recall session in pediatrics. So, the NEET PG 2023, which was held today, we will discuss the pediatrics questions. And before starting with the questions, let me tell you that it was a moderately difficult level of the paper, and there were specific areas which were focused in this year NEET PG. From pediatrics point of view, we have many questions from vitamins and a few questions from selected areas like mode of congenital infections, 2 or 3 questions regarding cardiology. All the questions were doable, and you just need to remember your concepts and one-liners, and you have surely rocked it. So let us discuss the recalls. A child presents with bleeding gums which occurs due to defect in. So bleeding gums in a child. So the most common what we can think is because of a vitamin deficiency, that is vitamin C deficiency, ascorbic acid, which occurs in scurvy. And scurvy is because of defect in collagen synthesis. So the option is A. Now we know in scurvy we'll have bleeding gums as well as we'll have pseudo paralysis. So the key points in the MCQs will be bleeding gums, pseudo paralysis, vitamin C deficiency, ascorbic acid, and it is a clinical diagnosis mostly, and it is because of defect in collagen synthesis. Now the second question on vitamins. Child is suffering from. So it was an image based question and this image was given. So you can clearly see that this is an image of genu varum. So this is genu varum, or what we call as bow legs. So this is a feature of rickets. In case of rickets, we can find knock knees as well, but bow legs are more common. And so let us see some images. So this is the genu valgum, that is the knock knee. I think you can appreciate this. And this is the genu varum, that is the bow legged. Both of these are characteristic of rickets, but genu varum is more common as compared to genu valgum. Now since we are dealing with the question of rickets, and rickets is a very important topic, so let us just briefly revise what are the clinical features that we can get in rickets. So there can be delayed closure of the fontanelles, there will be frontal bossing, delayed dentition and dental hypoplasia, white sutures, craniotapes. It's very important. It is the first sign of rickets seen in 6 months. So craniotapes is the first sign in rickets seen in 6 months. Apart from this, we'll have pectus carinatum, rachitic rosary, Harrison sulcus, swelling in the wrists and the ankle joints. Sometimes you can see in the paper it can be mentioned as the double malleoli. And the bowing of the legs. So this year the key word was bowing of the legs. And remember, radiologically, the first sign that you get in case of rickets is the loss of provisional zone of calcification. And we know the characteristic sign in rickets, that is the splaying, fraying and the widening of the metaphysis, right? So the first radiological sign that you can get in rickets is loss of provisional zone of calcification. Is the first radiological sign. Okay, so among this you should remember about the craniotapes and the bowing of the legs, frontal bossing, white sutures. These are the keywords which you can expect in questions later on. Now coming to the third question from vitamins. A child had thinning of hair, that is alopecia, with history of raw egg consumption. So these two keywords, that is alopecia, and even if you don't remember about alopecia also, this raw egg consumption, this only can give you the diagnosis that this is nothing else but biotin deficiency. Okay, so biotin deficiency, the most common cause can be because of consumption of raw egg. It can be because of high dose of valproate also, even in some cases where there is a prolonged case of TPN. The child is on prolonged TPN exposure. And then also we can have a biotin deficiency, and we can have alopecia. Okay, so alopecia with raw egg consumption is nothing but biotin deficiency. Now the fourth question, again from vitamins. A child presents with cardiomegaly, pedal edema and pleural effusion. So it's a feature of CCF. Now test to detect vitamin deficiency. Now you're asked that which vitamin leads to CCF. So I didn't get the exact recall of this question, but what I can make out is that it is nothing but vitamin B1, that is thiamine deficiency, and thiamine deficiency can produce a disease which is known as beriberi. And we can have two types of beriberi. One is the wet beriberi and the other is the dry beriberi. So beriberi can be dry beriberi and wet beriberi. In case of wet beriberi, it presents with cardiological features. That is, there can be cardiomegaly, CCF, pedal edema, which can be due to CCF as well, tachypnea. Dry beriberi mainly presents with neurological features. And one more one-liner for your future exams that you need to remember is that what is the most common cause of death in case of vitamin B1 deficiency if it is left untreated. So most common cause of death is again CVS because of dilation, and we can get some specific ECG changes as well, and those specific ECG changes include prolonged QT interval, okay. So here in this question, if I come back, which enzyme you are going to test to detect vitamin B1 deficiency, the answer is going to be transketolase, or specifically we need to say it's the RBC transketolase activity that we are going to see. So the option is B. One more thing I would like to say, in many cases you can also get the keyword that a child who is on polished rice or risk factor include prolonged and just when I was browsing in the recalls of this year NEET PG, I came to know that there was another question also asked from vitamin B1 deficiency, that is the thiamine deficiency, and that is nothing but about the Wernicke's encephalopathy. Okay, so in this Wernicke's encephalopathy, it was asked about what are the symptoms it was given, like the global confusion, ophthalmoplegia and ataxia. So this is nothing but Wernicke's encephalopathy, and the scenario was that about an alcoholic patient, and the lesion was in the mammillary body. So this is not related to pediatrics, but just I wanted to tell you this year vitamins played a very important part in the NEET PG paper, and definitely thiamine also played a very important part. So here at least you need to remember about the dry beriberi, wet beriberi presenting with the cardiological features, and the cardiological features being the most common cause of death. And how do you monitor the activity? It is by the RBC transketolase. Okay, and definitely one more thing about the Wernicke's encephalopathy, which you see in alcoholic patients, which you can remember by the mnemonic GOA, that is global confusion, ophthalmoplegia and ataxia. Now coming to the fifth question, again on vitamins. A patient presents with 3 Ds, and it's a cakewalk for you: diarrhea, dermatitis, and dementia. So we all know that this is nothing but it's the niacin deficiency, and the disease is nothing but the pellagra. So it presents with diarrhea. There is a dermatitis. We can have stock and gloves like predisposition, and there is dementia. And Casal's necklace is the term which is also used for pellagra, and we need to substitute with niacin only. And sometimes tryptophan can also be, you can substitute tryptophan in the diet also. You can remember 1 milligrams of niacin is equals to 60 milligrams of tryptophan, right? So diarrhea, dermatitis, dementia, these 3 makes pellagra, and 1 milligrams of niacin is equals to 60 milligrams of tryptophan, right? Now, 6th question again from vitamins. I didn't get the exact recall, but it was something related to the gamma carboxylation. Now, which vitamin undergoes gamma carboxylation? We all know it is the vitamin K. And from here, you need to remember about the vitamin K dependent clotting factors. So, what are the vitamin K dependent clotting factors? So it is factor 2, 7, 9 and 10. So factor 2, 7 and 9 and 10 are the clotting factors which are associated with vitamin K, and vitamin K is associated with gamma carboxylation. Now coming to one question from minerals, that is the zinc deficiency. So zinc deficiency leads to acrodermatitis enteropathica. I am not sure about the other options. Just I have put the options like Menkes disease, Menkes kinky hair disease. It is because of copper metabolism problem. So what you need to remember regarding acrodermatitis enteropathica, it is a disorder because of zinc deficiency. And zinc, please remember, zinc is one of the most important trace element, or rather the second most common trace element after iron. Now coming to few points regarding acrodermatitis enteropathica. Okay, so first of all, it is autosomal recessive. Now what is the gene involved? It is SLC39A4. So this is the gene involved in acrodermatitis enteropathica. Now the onset of this disease starts from infancy. So it starts from infancy. And what is the hallmark of acrodermatitis enteropathica? I'll just break the words. Whenever you have some confusion in any part of medicine, please break the words. Acro means peripheral. Dermatitis, that means there will be dermatological manifestations. And enteropathica, so rash. So usually we'll have perioral and perianal rash. Okay. So perioral and perianal rash. And what is the treatment that you give in case of zinc deficiency? Definitely it is a zinc, and it's a high dose of zinc that you give. It is 3 to 5 milligram per kg per day. Lifelong is what you give in case of acrodermatitis enteropathica. Now coming to 2 questions from hematology, and both are from oncological sector. Okay, a child with jaw swelling and translocation 814. I'm not sure whether any image was given in this question or not, but people saw jaw swelling and they were very happy that this is nothing but Burkitt's lymphoma, because translocation 814, the one of the most ominous things that we have read multiple times, and the jaw swelling is very classical with a very aggressive tumor is Burkitt's lymphoma, right? And we also put the image here of the Burkitt's lymphoma. It is the classical starry sky pattern. So this is nothing but the starry sky pattern that you find in case of Burkitt's lymphoma. Okay, so please remember the translocation 814, and it's a very high grade aggressive form of tumor. Now coming to the second important question from leukemia sector, following image is suggestive of. So what I got from the recall, one image was given, right? And in some students told me that the history was suggestive of DIC. So I am not sure about what was the exact recall, but I'll tell you what will be the answer here. So it is, just see the image here. At least you can see the arrow mark. Can you see? It is nothing but overwrought, right? So if you are finding overwrought in an image, that means you are dealing with AML. You are sure about that. Now see, there are multiple overwroughts that you are finding in this image. When you are finding multiple overwrought, right? So that is a faggot cell, and faggot cell is most commonly found in AML M3. So faggot cell, this is a faggot cell, and faggot cell is found most commonly in AML M3, which presents with DIC. DIC is a 3-lettered word, and M3 is also a 3. There is a 3. So this is how you can connect and remember that AML M3 is translocation 1517 PML RARA that presents with DIC. So this is AML M3 faggot cell, right? So using this, let us quickly revise the FAV classification of AML. So first is the M0. It is undifferentiated or minimally differentiated. Just remember 2 points from here, that is the deletion 7q and inversion 3q. And it is poor prognosis. M1 is myeloblastic without maturation. M2 is again myeloblastic with maturation. So that is why you have the MPO positive over here. If you're asked in question chloromas, just in any questions in MCQs, try to find out the keywords. These keywords are going to help you in solve questions, and also it will help you to buy your time during writing the paper. So chloromas, if you find in a leukemia question chloromas, you should think that the question paper is asking about AML M2. Again, DIC, faggot cell, which I said, multiple overwroughts. It's translocation 1517 PML RARA. It is AML M3 or acute promyelocytic leukemia, right? Next, M4 is myelomonocytic. M5 is monocytic. M6, again you should remember, it is erythroleukemia. And AML M7 is megakardioblastic, which is associated with 2 things. One is the Down syndrome, and the number 2 is the myelofibrosis. So future questions from this chart, what you can expect is chloromas found in AML M2, multiple overwroughts or faggot cells found in AML M3. APML is AML M3. PML RARA translocation AML M3. Translocation 1517 again AML M3. Down syndrome is associated with AML M7, and myelofibrosis is associated with AML M7. Hope you got a very brief idea about the classification, FAB classification of acute myelocytic leukemia, right? AML. Now coming to 2 questions from Kadleji. Mid-diastolic murmur with prominent A wave in JVP. Many students got confused seeing prominent A waves with mid-diastolic murmur, and they were not very sure about what will be the answer. And whenever we see the question of mid-diastolic murmur, the first thing that comes to our mind is mitral stenosis. But there was another part to this question, is prominent A wave in JVP, right? So prominent A wave in JVP, these 2 combined together, the answer will be tricuspid stenosis. So let us briefly look at the waves of JVP, right? So first see the waveforms of JVP. So can you see the positive waveforms, that is the A wave, the C wave and the V wave. And we have the 2 negative descents, that is the X descent and the Y descent. Now we'll read that why does this waves occur. First is the A wave. A wave is because of right ventricular contraction, right? So whenever the right ventricle contracts, so blood is pushed up in right atrium contracts, blood is pushed up into the internal jugular vein. That results in a positive deflection, that is A wave. What about the X descent? So right atria relaxes. That is why there is a drop in pressure and you get a negative deflection. C wave. There is closure of the tricuspid valve and the right ventricle contracts. And that results in a slightly increased pressure. That is C wave. What about V wave? It is feeling of the right atrium against a closed tricuspid valve. So right atrium gets filled with blood. Again, there is a positive deflection. Whereas Y descent is because of blood from the right atrium now goes to the right ventricle. Because of the opening of the tricuspid valve, that results in Y descent. Okay. Now, after knowing which waveform it is because of which physiology, now you need to remember what is the pathology behind every waves. First is the absent A wave. It's a very common question, is because of atrial fibrillation. Where the atria contracts, what happens? It's a type of arrhythmia, right? So in atrial fibrillation, you're not going to get any A wave. Whereas large A wave, you're going to get in pulmonary hypertension, tricuspid stenosis and pulmonary stenosis. Canon A waves are found in complete heart block and ventricular arrhythmias. Whereas large V waves, also known as CV waves, sometimes the C and V waves can join, which is known as found in tricuspid regurgitation. And whenever the child is inspiring, where there is a rise in JVP, this is known as Kussmaul's sign, and this is found in constrictive pericarditis. So mid-diastolic murmur, MDM, you get in mitral stenosis and tricuspid stenosis. Tricuspid stenosis results in a prominent A wave in JVP or a giant A wave in JVP. So together the answer is going to be tricuspid stenosis, right? So hopefully I am clear with a basic understanding of JVP waveforms. Now coming to the second question, again from murmur. Following is suggestive of. So this is an image based question, and you can find that there is one murmur which starts from S1, that is the first hertz sound, and it covers and reaches S2. That is, it is a holosystolic murmur or a pan-systolic murmur. So we are dealing with a holo or a pan-systolic murmur. So if I am dealing with a holosystolic or pan-systolic murmur, we have only few differentials for this. Number one is ventricular septal defect, number two is mitral regurgitation, and number three is tricuspid regurgitation. Amongst them, in children, usually we think that the pan-systolic murmur is because of VSD, and in adolescent age group or adults because of rheumatic origin, we can think about mitral regurgitation. So here the answer will be mitral regurgitation. I don't know whether the age group was mentioned or any history mentioned in the question was not, but students told me that it is about a pan-systolic murmur. So remember, in pan-systolic murmur we have only few DDs only. One is the VSD and AMR and TR. So here the answer will be AMR, not MS, because MS you are going to get a mid-diastolic murmur, and in no way we are having a mid-diastolic murmur here. Again, in tricuspid stenosis also we'll get a mid-diastolic murmur. In aortic stenosis we get a crescendo decrescendo murmur. So it is not seen in this waveform, right? So it is clearly a pan-systolic murmur. Now third question, and it is from a ECG. So which drug is implicated here? That means which drug causes this type of ECG? This is the question. Now, few students told me that there is a certain variant to this question, like a lady presented, it is not about child, it's about a lady who is having hypertension and is on antihypertensive medications and has asthma too, and presents to the emergency, and an ECG strip is being taken which shows the following. Now, which drug is implicated here? That was the question. Now, whatever be the thing, just if you see the ECG, your diagnosis is met. The very first thing that from the ECG you can make out is something which is associated with tall T waves. So this is nothing but you are getting tall picked T waves. And whenever you get tall picked T waves, it is the first sign of hyperkalemia. So this is the first sign of hyperkalemia, right? So, and which drugs can result in hyperkalemia? I haven't received the exact recalls of all the options, but there was one option, spironolactone. So spironolactone can result in hyperkalemia, and it can result in a life-threatening hyperkalemia if it is associated with ACE inhibitors. So if a lady who is hypertensive, if she is on ACE inhibitors, along with that, if she is taking spironolactone, it can result in life-threatening hyperkalemia, right? Now, let us revise some other drugs which can result in hyperkalemia. So, we can have digitalis, again beta blockers, we can have fluoride as well, ACE inhibitors plus spironolactone, and one muscle relaxant which we commonly used in anesthesia. Nowadays it is not much used, that is choline, succinylcholine. So these drugs can result in hyperkalemia, right? Now the first sign is what you get is a tall picked T waves. So that gives you that which electrolyte abnormality you are expecting. The answer will be hyperkalemia. Next you get an ST segment depression. There is a prolonged PR interval, and as soon as the potassium level increases, the picture is not like this. The picture changes. You have got white QRS complexes, and this white QRS complexes merges with the tall T wave. So fusion of the white QRS complexes with the tall T wave gives you something which is known as the sine wave. So this is the sine wave pattern, which is because of fusion of tall T waves with the white QRS complex, and this is what you get in late stage of hyperkalemia. And you can, whenever you see this ECG in your ER, okay, so you can think that the potassium level is around 8. So you need to act very fast because it can go to asystole and arrhythmias, right? So this is a late hyperkalemia ECG, and the one which was given this year NEET PG to 2K23 is about the early change, where you can find the tall T waves, and it's very easy to diagnose that this is nothing but hyperkalemia. Now next question from radiology or pulmonology, what you say. So this is first of all, what is important in this image is that it is either an AP view or a PA view. Whatever the chest X-ray, it is not a lateral view. This is what I need you to understand. Okay, so this specific sign that you get it in an AP or a PA view of chest X-ray, not in a lateral view, right? And that makes you the diagnosis. When you see that this pattern, can you see this? See the arrow mark? I'll just outline it for you. So this is shaped like something like a charge stipple, okay, and this is known as the charge stipple sign. And charge stipple sign is a characteristic of acute laryngotracheobronchitis. Or better known as croup. Okay, so this will be the answer. Now whenever we see croup, we need to differentiate it from acute epiglottitis. So croup is basically a viral disorder mainly caused by para-influenza, and you are going to get some prodromal upper respiratory tract symptoms. The child is not going to be much toxic. There is going to be a low grade fever, and there is not much toxic child. There is going to be no drooling of saliva, and since it's a viral thing, antibiotics are not going to be helpful. The child will present with biphasic stridor. Some students have told me in this question the word biphasic stridor was there. Okay. So in X-ray you will get the charge stipple sign. This was asked in the paper. And what we give racemic adrenaline nebulization, and we can also give a oral dexamethasone. Antibiotics are not helpful. Again, acute epiglottitis is either because of strep pneumoniae or Haemophilus influenzae, right? So what happens here? The child is very toxic. Why? Because it is bacterial, right? So I just want to see you the X-ray first, and later we'll read the symptoms what we get in acute epiglottitis. See, the first thing, you appreciate that this is a lateral view, right? And this, the arrow, just try to think, it looks like a thumb, right? It looks like a thumb. So this is known as the thumbprint sign or a thumb sign. So this is suggestive of acute epiglottitis. So let's go back. So it's a high grade fever, toxic child, there is going to be drooling, there is going to be stridor, and we need to start the child on an IV antibiotics and ceftriaxone. So X-ray, lateral view X-ray will show you a thumbprint appearance. Okay, so differentiating between croup and epiglottitis is very important for your subsequent exams, even for your INE set. This is very important images. Now coming to this question, this was there is a great bit of controversy regarding this question, though I didn't understand why there was controversy. It is a 2-month-old child who presents with a scalp swelling, and the swelling was present since birth, and the X-ray is shown. What is the diagnosis? So the options were caput succedaneum, cephal hematoma, subgaleal hematoma, and intraventricular hemorrhage. Before telling you what will be the answer and how to rule out these options, I'll just tell you the differentiation between caput succedaneum, cephal, and subgaleal hematoma. See, intraventricular hemorrhage is a diagnosis usually occurs within day 3 of life. Intraventricular hemorrhage, if I'm talking about in a neonate, 50% in day 1 and 75% by day 3, right? And usually you pick up intraventricular hemorrhage either by a CT scan or a USG based. Okay, just by doing an X-ray you do not understand intraventricular hemorrhage. You can, but it's very difficult. You do not understand it. So this is ruled out. Now coming to the 3 differentiations between caput succedaneum, cephal hematoma, and subgaleal hemorrhage. So look, first point is very, very important. Caput succedaneum can extend across sutures, and it is located at the point of contact. Whereas cephal hematoma, it is a hematoma, it is blood. It is usually over the parietal bones and it do not cross the sutures. This is very, very important statement which you should remember. And subgaleal hemorrhage is beneath the epicranial aponeurosis. Okay, it is beneath the galea, and it may extend to orbits and nape of the neck. So only thing which do not cross the sutures is cephal hematoma. Next, caput succedaneum, since it extends across sutures, there is no specific margins, right? So pitting edema that shifts with gravity, whereas cephal hematoma will have distinct margins, initially firm, and it is more fluctuant after 48 hours. Whereas subgaleal hemorrhage is again firm to fluctuant, and again it has ill-defined borders. So distinct margins again goes in favor of cephal hematoma. Now the third thing, that is the timing. Caput succedaneum is maximal at birth and it is most firm at birth. And very important that it resolves in 48 to 72 hours. That is day 3 of life. Whereas cephal hematoma increases after birth for 12 to 24 hours and it goes away later. That is resolutes over 2 to 3 weeks. And subgaleal hemorrhage also resolutes over 2 to 3 weeks. Since cephal hematoma and subgaleal hemorrhage, they stay, so these are prone for neonatal jaundice, not caput succedaneum. Okay, so volume of blood is minimal in caput succedaneum. Cephal hematoma, it's rarely severe, may be massive and associated with coagulopathy in subgaleal hemorrhage. Now you go back to the question and see the X-ray image. So can you see a swelling over here, and can you understand the distinct margin, and can you understand that it is not crossing the sutures? So 2 points in favor of cephal hematoma. Caput succedaneum is already ruled out because it resolves by day 3 of life. It cannot stay. So since it is having a distinct margin and it is not crossing sutures, so the best answer over here is cephal hematoma. Hope I have made this clear very clearly about the scalp swelling. Now another very important question, and this there are two questions which was asked this year, and I'll just say the questions. That is, a child presented with petechial rash, hepatosplenomegaly and jaundice. Congenital infection scan was done, that is TOT screen was done, and centrifugation of CSF showed owl's eye appearance. So this is a clincher, that is the inclusion body. It's a microbiology question basically. It's a cytomegalovirus. But what I need to stress this, that this topic is very important, congenital infections, and cytomegalovirus is the top short topic which is repeated in every exam. You can expect a question from cytomegalovirus in your upcoming INSET exam as well. Okay, so cytomegalovirus, here the clue already given: petechial rash, hepatosplenomegaly, jaundice and owl's eye appearance. Now congenital infection also we are saying. Now the torch infection and the most common infection, owl's eye appearance, what can be other than CMV? Now the second question from CMV which we had in this year NEET 2K23, periventricular calcification with sensorineural hearing loss. Again, two very important keywords, SNHL and periventricular calcification. Again, it is nothing but CMV. Because you know what happens in hearing loss, let me tell you that mainly we have genetic cause and non-genetic cause. And regarding the genetic cause, we have few cases which are syndromic, like neurofibromatosis, Usher syndrome. All these are associated with genetic syndromic cause of hearing loss. And genetic non-syndromic, we have connexin mutation. Now non-genetic cause of sensorineural hearing loss, whenever we are suspecting, so it is always cytomegalovirus. So whenever in NICU, when we are at 1 month, usually we go for the screening thing we need to do. Like we did the evoked autoacoustic emission, it has got a referral. We did it again it is a referral. Then we do the beta and there is a hearing loss. We need to go for TOT screen, right? Because we need to rule out cytomegalovirus. And even we can go for a CT scan to find out whether there is a periventricular calcification. Now can you tell me, diffuse calcification is found in toxoplasmosis. So periventricular calcification is cytomegalovirus and diffuse calcification is Toxoplasma gondii. So this is the CT scan, okay? And can you appreciate the periventricular calcification? Okay, so this is the periventricular calcification found in cytomegalovirus. So it is the most common torch infection. Few one-liners from CMV. Since this is the one of the most important exams which you can get, 90% cases are asymptomatic. Very important. Most common non-syndromic cases of sensorineural hearing loss, but in those patients who are having sensorineural hearing loss, we have 30 to 40% cases who are symptomatic. Now clinical features, you remember the most common clinical feature is petechia. Apart from that, you can get hepatosplenomegaly, jaundice, pneumonia, microcephaly, very important, chorioretinitis and intrauterine growth restriction. Laboratory abnormalities, you can get elevated AST, ALT, thrombocytopenia and jaundice. Okay. So periventricular calcifications, the vertical transmission is maximum, the risk is maximum in 3rd trimester, but the infection, if the infection is less than 20 weeks, the fetus is more severely affected. Virus can be isolated from saliva or urine. Remember a dictum from all the congenital infections, that is, if it is affected in the first trimester is the period of organogenesis. So the fetus will be affected more. But the maximum risk of vertical transmission is always in the 3rd trimester. Now coming to the next question, a child with cough and coryza with Koplik spots, diagnosis is. So this is a very cakewalk, it is measles. So measles presents with 3 C's. One is the cough plus coryza plus conjunctivitis and the Koplik spots are also mentioned in the question. Remember the most common complication is acute otitis media, and the most severe complication which can result in death is measles pneumonia. And whenever a patient is with measles, you need to give vitamin A prophylaxis because of vitamin A deficiency. There can be diarrhea as well. And late and fatal complication of measles is SSPE, that is subacute sclerosing panencephalitis with presence with myoclonic jerks and dementia. And it is a one-way story only, that it leads to death. So a child born premature with LBW, decreased hearing, so already you are having the symptoms like SNHL is there, cataract is there, and a heart defect, that is PDA. So this is nothing but the triad of congenital rubella syndrome. Again, another question from congenital infections. So here the answer will be rubella. So and in case of rubella, the most common cardiac defect is patent ductus arteriosus. Apart, if the patent ductus arteriosus is not there in the question, you can also get pulmonary stenosis. Okay. Now there was one more question regarding patent ductus arteriosus. I have not included it in my recall session just because it's an anatomy question, but I'll just tell you that is ductus arteriosus is a communication between aorta and the pulmonary artery in the fetal period, right? During fetal to neonatal transition, this ductus arteriosus anatomically closes in 10 to 21 days. Now ductus arteriosus, okay, it is, the question was derived from, the answer is left sixth aortic arch. So left sixth aortic arch, right? So this is rubella, cataract, sensorineural hearing loss with patent ductus arteriosus is nothing but congenital rubella syndrome. A 5-year-old child presents with cola colored urine. Okay, so we have hematuria, facial puffiness, hypertension. And okay, and the second point actually clinches the diagnosis, that is history of skin infection 2 weeks back. So we are dealing with nothing but PSGN, so post streptococcal glomerulonephritis, and we all know in post streptococcal glomerulonephritis we'll have lumpy bumpy deposits or nothing but the subepithelial deposits. So lumpy bumpy deposits. So this is something which we are reading from our Robbins pathology days. So subepithelial deposits. So few things which we should know from PSGN point of view, post streptococcal glomerulonephritis is because of group A beta hemolytic streptococcus nephritogenic strains, the serotype being 1249. The most common age group being 5 to 12 years. It can present with acute nephritic syndrome, that is hematuria, edema, oliguria, and the complications can be hypertension, encephalopathy, blurring of vision. And it can lead to RPGN, rapidly progressive glomerulonephritis. So it is 1 to 2 weeks after an antecedent streptococcal pharyngitis or 3 to 6 weeks after a streptococcal pyoderma. So it will present with cola colored urine, edema and oliguria. And you need to remember about some danger signs which I already told: hypertension, encephalopathy, and RPGN. So in the light microscopy, there is going to be diffuse proliferation. In the immunofluorescence, there is going to be deposits of IgG and C3. Electron microscopy, there is going to be subepithelial humps. This was given in the question. Treatment is supportive, 90% resolved spontaneously, but 5% developed rapidly progressive glomerulonephritis, right? Okay, so this is the picture. So this is the electron microscopic picture here, where you are going to get the subepithelial humps. This is the fluorescent, where there is a IgG and C3 deposit. So that is why there is a decreased C3, but it is transient. Okay, if there is a persistently low C3, C4, it is lupus nephritis. Again, another important question. Okay, and there is diffuse proliferation which you can find out in this image. Urine which turns black on standing in a child. It's a much repeated question. It's alkaptonuria, homogenticid, oxidase deficiency. So regarding alkaptonuria, it is the first inborn error of metabolism to be diagnosed. It is autosomal recessive 3q. Remember this for your future. Homogenticet oxidase. Urine stands black or urine darkens on standing. There is going to be ochronosis, ochronotic arthritis, renal stones, and calcification of heart valves. We treat by giving vitamin C and nitazoxanide. Again, this is a future MCQ question. This ochronosis is also a future MCQ question. And again, this thing also. So this is the picture. This can be a potential IBQ. That which enzyme is deficient here? The answer is homogenticet oxidase, alkaptonuria. So a child with no hepatosplenomegaly, blindness, presence of cherry red spot with mental retardation, the diagnosis is. See, cherry red spot, whenever you are seeing, you must be confused between Tay-Sachs and Niemann-Pick's, right? I don't know about the fourth option, but what is important is here that there is no hepatosplenomegaly. And this is the key word in this question, which is nothing but Tay-Sachs. So Tay-Sachs disease is because of hexosaminidase A. And the child can present with a startle response. So this is another key word which you can expect in your future question regarding Tay-Sachs, that there is a child can present with a startle response. Okay. Cherry red spot, blindness, there can be dysphagia, dysarthria, cognitive decline, there is mental retardation, but there is no hepatosplenomegaly. Usually in all inborn error of metabolism, we always think that there is microcephaly, hepatosplenomegaly, jaundice, but it is not so in all cases. Tay-Sachs is one of the exceptions. Coming to question number 21, a patient with H-base Ag positive, that is hepatitis B, along with a spike and dome appearance. So this is nothing but membranous glomerulopathy. So membranous glomerulopathy will have the characteristic spike and dome appearance, and we have hepatitis B positivity, right? A neonate presents with respiratory distress. I think the question was not so simple like this. It was like a child presents, neonate presents with tachypnea, chest retractions, increased work of breathing, and mimicking hyaline membrane disease, or X-ray showing a ground glass appearance. Like this was the question. But students told me that the question was regarding respiratory distress syndrome, that is the hyaline membrane disease, and the question is asking about which is the most likely deficient, right? So you understood that this is basically surfactant deficiency, right? What is surfactant? It is dipalmitoyl phosphatidylcholine. It's not given in the options. So we know, because to see whether hyaline membrane disease, the most important risk factor is prematurity. So what we see is the LS ratio. So what is LS ratio? It's the lecithin sphingomyelin ratio. So if it is less than 2, it indicates prematurity. So if it is 2 to 2.5, it is a mature thing. So what is most likely deficient? The answer is going to be lecithin. Okay. A baby with pale stool, rising conjugated bilirubin. I think this is the clincher. Pale stool with conjugated hyperbilirubinemia, ductal fibrosis. It is nothing but biliary atresia. So it is the most common cause of neonatal cholestasis. So this is a very, very simple question. I'll just tell you 2 to 3 points regarding neonatal cholestasis. That is presence of conjugated hyperbilirubinemia beyond 14 days of life. And remember, whenever you see conjugated hyperbilirubinemia, it is never physiological. It is always pathological, right? So the direct fraction is more than 20% if TSB, that is the total serum bilirubin, is more than 5. And if TSB is less than 5, then the direct fraction is more than 1. So this is the definition of neonatal cholestasis. So when you suspect neonatal cholestasis, this is what I would like to ask. A mother complaining to you with persistently pale stools, high colored urine, staining the diapers, conjugated hyperbilirubinemia, you are going to suspect neonatal cholestasis, right? And whenever you suspect neonatal cholestasis, there is a huge lots of causes of neonatal cholestasis, but at least you should remember 2-3 causes. Like most important cause is extrahepatic biliary atresia, and second most is idiopathic neonatal hepatitis. Other than that, we have the torch infections, sepsis, alpha-1 antitrypsin deficiency, galactosemia, inborn error of metabolism, Allergy syndrome, etc. Okay. So regarding biliary atresia, at least what you can remember is that you can do the LFT where you can find that there is raised GGT, alkaphos will be more, 5-nucleotidase, all the obstruction, causes of obstructions are going to be more. You do a USG after 4 hours of fasting and you get the triangular cord sign. Non-visualization of gallbladder or micro gallbladder. HIDA scan you can do, but it is sensitive, not specific, and it requires a delay of 5 days because there is requirement of phenobarbital priming. ERCP and MRCP can be done in older pediatric population, and the gold standard is what you are asked in the paper is liver biopsy with intraoperative cholangiogram. And remember one point, that you differentiate from extrahepatic biliary atresia from the neonatal hepatitis. In neonatal hepatitis, hepatic architecture is not preserved, whereas in biliary atresia, hepatic architecture is preserved. So hepatic architecture is preserved in biliary atresia. And what is the name of the surgery that you perform? Is Kasai operation, portoenterocystostomy. And the best outcome you get from Kasai if it is done before 8 weeks of life. So that is why it is very, very important that whenever you see neonatal cholestasis, you do a USG, you do a HIDA scan, you go for a liver biopsy, because you need to find out biliary cholestasis because time is very limited. Less than 8 weeks, you need to go for the Kasai operation. Okay, because type 3B biliary atresia is the most common, type 3B, where there is obliteration of all the ducts. Okay. So apart from this, what you need to remember, that other causes of neonatal cholestasis include neonatal hepatitis, number 2 is the sepsis, urosepsis as well, torch infections, galactosemia. For that you do the urine for reducing substances, urine for non-glucose reducing substances, and Galliput enzyme assay. Other IEMs you can think about, even hypothyroidism is one cause. Some syndromic cause like Allergy syndrome and Agnès syndrome. Allergy syndrome, you are going to have a typical facies, a cardiac defect, that is branch pulmonary stenosis, neonatal cholestasis, vertebral defect, and eye defect. Okay, so this is again a potential, it's a JAG1 or Notch2 mutation. It is because of, you're going to get facial dysmorphism plus cardiac defect. And cardiac defect, already I told you, it is the branch pulmonary stenosis. Vertebral defect, the specific vertebra you get is the butterfly vertebra, and eye defect, and definitely associated with neonatal cholestasis. And another thing that you need to remember regarding biliary atresia or any neonatal cholestasis management. You need to supplement with vitamin A, D, E, K. You need to give water soluble vitamins as well in twice the recommended daily allowance. Even you need to give calcium. MCT oil, that is the medium chain triglycerides, 15 to 20% of calories. You need to manage pruritus. Pruritus is managed by ursodeoxycholic acid. You need to symptomatically manage the liver disease, and the last option you have is definitely orthotropic liver transplant. And I utilized this slide to give you one important one-liner from this. That is the most common cause of liver transplantation in children is because of biliary atresia. Okay, so biliary atresia is the most common cause of liver transplantation in children. So I don't know the exact recall of this question. It's a crumpled tissue paper appearance, and my students told me that this image is like this only. So this is nothing but Gaucher disease. I would like you to understand that Gaucher disease is because of beta glucocerebrosidase deficiency, and enzyme replacement therapy is available. Very important. Enzyme replacement therapy is available for Gaucher's disease, and this is the specific crumbled tissue paper appearance which you get. Okay, just remember this image, and it is beta glucocerebrosidase deficiency. It's a lysosomal storage disorder. Okay. Now this is a very important question. I don't know whether I received the exact recall of this question or not, but I will try to give you the concept. A 10-year-old child presents with pH 7.01, sodium 158, random blood sugar 550, and urine sugar 3+. I think it is going to be urine ketone, not sugar. But my students told me that it is written urine sugar, so I am very confused about this, but definitely what my sense is still that it is going to be urine ketone, because which is true as per ISPERT guidelines. So I think you understood that it is a diabetes, that is hyperglycemia is there, ketonuria is there, and acidosis is there. So we have diabetic ketoacidosis. So this is a question of DKA, which is a complication of type 1 diabetes mellitus in children. So now the question is not asking you about what are the clinical features of DKA, because what happens in children, classically the polyuria, polydipsia, there can be there in the child, but the child may not come to you in the OPD, or the mothers or the informant may miss it. So the child may present with the first episode of diabetic ketoacidosis, and while managing DKA, you might understand that you are diagnosing the child to be of type 1 diabetes mellitus for the very first time. So there can be history of nocturnal enuresis, there can be polyuria, polydipsia, weight loss, but when the child presents to you in the emergency, there is going to be rapid walk of breathing, right? So there is going to be the fruity smell, abdominal pain, vomiting can be there. There can be a history of infection, like fever can be there, a UTI or a chest, some triggering factors can be there. So this is nothing, or in case of female, genital candidiasis can also be there. So this is the precipitating factor for diabetic ketoacidosis. So you break the words diabetic ketoacidosis, it is hyperglycemia. So the blood sugar will be more than 200, that is 550 over here. Ketonemia or ketonuria will be there, that is the blood ketones are going to be elevated, or the urine ketones are going to be positive, and acidosis are going to be there. So which is true as per ISPERT guidelines, right? So I don't know about the exact options, but whatever we find, that whenever a child comes to me, we try to get a electrolyte. Okay, we do a VBG or a ABG, that is a blood gas we do. Usually venous blood gas is preferred in diabetic ketoacidosis because the classification system is based on venous blood gas, and also there is a risk of thrombosis, so we do not prick the artery every time. Okay, and we refrain from doing any catheters or any lines in a decay patient because there is a chance of thrombosis. So whenever a child comes to me, we try to grade the severity of decay. So let us just see a screenshot from the ISPAT guideline itself. So this is the severity of the decay is categorized by the degree of acidosis. So it's a venous pH less than 7.3 and a bicarb of less than 18 is mild. If it is less than 7.2 and bicarb less than 10, it is moderate. Whereas if it is pH less than 7.1 or bicarb less than 5, it is severe. So whenever it is a severe dehydration, severe decay, we consider it to be 10% dehydrated. So whenever a child comes to me in an emergency with symptoms, it is not a mild decay, usually it is moderate to severe decay. Because when a child is symptomatic, it is severe decay. So here, as you can see in the option, it fits in the category of severe decay, pH less than 7.1. Okay, so the child is dehydrated, but there is no mentioning of the pulse volume BP in this question. So we don't know whether the child is in shock or not. Now come to the next guideline. So usually in case of first we correct the dehydration by giving a bolus over 30 minutes to 1 hour, and then we start with the resuscitation fluid and the insulin. So this option is wrong because we never start insulin and NS bolus together. So I am very much unsure about the C option. So either the answer is going to be A or D. So if the child is in shock, then the answer is going to be D. That is, we give 20 ml per kg over 1 hour and then insulin. And if the child is not in shock, the answer will be A. I'll prefer option A because here it is mentioned the hypernatremia. So one of the dreaded complication of DKA is cerebral edema. So the main thing in DKA is you need to create a balance between the fluid and the insulin. Because if you give more of fluids in judicious use, it can result in worsening rather than improving. So whatever you need to give in decay, it's a very judicious balance. And remember, DKA is a very rewarding disease because the child is drowsy, the GCS is poor, the child is having acidotic breathing, the parents are very much tense. But after a few hours, the child improves, the GCS improves, and it is definitely a reward for the pediatrician, right? So let's come to the next guideline. Again, this is another screenshot from the ISPAT guideline itself. So let's see what the ISPAT guidelines have to be are saying about this. For patients who are volume depleted but not in shock, volume expansion resuscitation should begin immediately with 0.9% NS, 10 to 20 ml per kg infused over 20 to 30 minutes to restore the peripheral circulation. If tissue perfusion is poor, that means if the child is in shock. The initial fluid bolus should be 20 ml per kg. So in the rare patient with decay in shock, rapidly restore circulatory volume with 0.9% NS in 20 ml per kg boluses infused as quickly as possible through a large bore cannula with reassessment of circulatory status after each bolus. So now I think you understood that what will be the resuscitation fluid, and we do not start insulin initially, we first give the fluid. The initial fluid management dictates how good a decay child will improve. Since here if the sodium is mentioned, I'll prefer 10 ml per kg bolus. Okay. Now coming to the last question, I didn't get the options, all the options, which is true. Please help me in the comment box regarding the options which were there in this question and help me to build up this question, because none of my students actually told me that what was the exact question and what was the exact recall options. But I will try to give you the exact concept regarding this, which is true regarding infant with 2.8 kg body weight. So it's an infant, right? So, and the body weight is 3 kg. So it's anterior fontanelle closure by 6 months. This is not true because anterior fontanelle closes by 18 months. If it closes prematurely, it is called craniosynostosis. So anterior fontanelle is a diamond-shaped space. It is because of the fusion of the joining of the sutures like coronal suture, metopic suture and the sagittal suture. Okay, and it closes by 12 to 18 months. And there were some questions regarding the anthropometry. Okay, so first is the height gain. So this we'll just write down. So what are the height? So at birth it is 50 centimeter. So at 1 year of age it is 75 centimeter. 2 years it is 85 centimeter or 90 centimeter. 4 years it's 100 centimeter. So you can just see that at birth it is 50 and 4 years it is 100. So height doubles or length doubles at by 4 years of age. Okay, so if your next question is about the height velocity. So again you need to remember this, that 0 to 16 months it is 16 centimeter, 6 to 12 months it's 9 centimeter. So in 6 months we are going to have total of, in 1 year we are going to have 25 centimeter. I think this is only asked in the paper, that is 25 centimeter, but I don't know the exact record. 1 to 2 years it's 12 centimeter per year, and 2 to 5 years it's 6 centimeter per year. 5 to 10 years it's 5 to 6 centimeter per year. So here it is 16 plus 9, it is 25 centimeter in 6 months plus 6 months, that is 1 year period. Okay, this is the height velocity. Now this is a very easy formula to understand about the weight gain. So if I think about the body weight of a child is x, in 5 months it is 2x. So 1 year it is 3x, 2 year 4x, 3 year 5x, 5 year 6x, 7 years 7x, and even in 10 years it is 10x. So if you know this, you can be able to answer any question on weight gain, how much weight gain a child takes place. Okay, so these are the recalls from pediatrics point of view. Please let me know if there are any other further questions, and please post your doubts also in the comment box. This year NEET PG session, majority of the question were based on vitamins, and the other questions were doable. Please revise this. Hope you have all fared very well in your exams, and we all expect a very good rank from you. Thanking you. Please post your doubts and exact recalls if possible in the comment section, or do ping me in my Telegram group or in the email if possible. Okay, thank you.